Although we want to know the end of the story, man. It's
No.
a
Yeah,
really
yeah.
interesting case. It's like a cliffhanger.
Do you know what happened? All of a sudden, I was like kicked out of
Yeah,
Zoom.
something happened on this end here. I don't know.
I want to know the end of the story, man.
You guys still here?
Yeah.
Okay, we got some people back up here. Sorry everybody, something happened on our end. Someone I think logged into my Zoom account and changed it. Someone here at home probably, or someone tried to start another meeting. So we'll give everyone maybe just a chance to log back in. I think we got many of you back already. So I apologize for that. So Ala, maybe let's go back to where you were.
Yep,
You
sure.
were gonna show the imaging, I think, right?
Yep. Is everyone seeing the UBM?
Yeah.
Yeah. So actually, before we got kicked out, I was asking the panelists, but yeah, I was thinking of asking like, what do you think about the changes, or like what significant difference do you see between both eyes?
I mean, this is a classic axial shallowing of the lens diaphragm here, and the only reason this eye hasn't fully collapsed its anterior chamber is because there's no outflow. The angle is zipped shut, so there's tamponade from the anterior chamber with that pressure in the 20s and 30s holding back the lens and iris. So if there was a trabeculectomy in this eye, this would be a flat chamber, for example. So to echo Ike's point earlier.
Yes.
And
Yeah,
sorry, go ahead. Go ahead.
I was just going to say that, yeah, this is a very telling UBM. Once you've ruled out any retinal pathology, there's really only three things on your differential here, and you can really use your slit lamp exam to determine. One is posterior synechii, which are holding the lens up. The second one is that the lens is actually in the sulcus. And then the third one is malignant glaucoma. And I think there were some comments earlier. I get told often that malignant glaucoma only has a dramatic presentation. And I would say it only has a dramatic presentation if you're only looking for a dramatic presentation. If you're looking for subtle presentations, such as this one, which was probably right away at the beginning after the surgery, then you will see that some of these people get this subtle picture, and then some of the physiological mechanisms that Manjul just eloquently described make it so this doesn't go bad until there's 360 degrees of PAS.
I just want to highlight that this happened quite early post-operatively because post-op day 1, angles were relatively open, at least in 3 quadrants. So something happened, because there was an IZHV, there was an iridozonulo-hyaloidovitrectomy at the time of initial surgery, right? If I'm not mistaken. So something blocked that communication between the anterior and posterior segment, and that unicameral eye was lost. And then the mechanism just kept going and increasing until the angle is basically zipped up over 360 degrees. So this is where you have to be, it's not because you did a iridozonulo-hyaloidovitrectomy that you are free and clear of having malignant glaucoma later on. If there's any obstruction to that unicameral eye, it can still reappear. So whether it's an inflammatory membrane or something obstructing it in the posterior chamber, whether it's sommering, something that can block it, so it's something to be mindful of.
And do you think, like, interestingly, that the use of glaucoma medications have kept this subtle, as if you're keeping the patient on a prophylactic malignant glaucoma treatment, and maybe this kind of kept the chamber stable so far?
I think this is more to Manjul's point that once it was zipped up, it's pretty much, it's not going to move that much more than what it is. It can, but typically it won't, because it's just, there's no outflow at all.
Yeah, and a classic mistake here would be to call this, they call this combined mechanism, and now you have an open angle dysfunction and do some sort of external filtering procedure. That would be a classic mistake in this context.
Exactly.
And it could be catastrophic.
Exactly.
Yeah,
I
that's
totally
great,
agree with you.
Joel. I think that is such a great point. I think that would just be disastrous here. I think I can just predict it. This patient would get, even worse shallowing. I mean, there's no question when you have the UBM in front of you, the luxury of seeing the difference in the asymmetry and similarly length eyes. Clinically, it may not be as obvious. I mean, you see a pretty deep chamber when you look clinically, and Ella said it was about 5 corneal thickness, central corneal thickness in depth, and it looks pretty similar. And so, but however, the angle is zipped up, and obviously you see why, because of the subtle peripheral pushing by the Sommerings ring, which is now present. So yeah, I think this is, having your sight set on this, and of course the refraction gives it away as well, in that
Yes.
there is some more myopia. And then the other thing is that we were looking at these things as well. I mean, I don't know if, I think Ala, maybe you're pointing it, not so much there, that looks like more artifact, but the one below that, there's a question of whether there might be some fluid present, an annular anterior effusion present, which sometimes can cause some anterior positioning of those ciliary processes, which we know in small eyes, and particularly in anophthalmic eyes and thick sclera eyes, that these patients can develop effusions. And so, there's a lot of things that are at play here. They can all present in similar ways. I've always kind of argued, can you get an effusion and malignant glaucoma at the same time? It doesn't quite make sense to me if that were to happen, but the similar manifestation clinically, chamber shallowing can look the same though. And the treatment also may be similar in the sense that once you re-equilibrate the anterior segment and the posterior segment, and you can allow the pressure to equilibrate, that you can resolve whatever is pushing from behind. The only difference is, of course, in effusion, you typically want to address by draining, because that effusion isn't necessarily going to go away, and that can be quite significant. While malignant glaucoma, the expansion of the choroid that can occur can often stabilize with treatment and with, again, pressurization equality between the front and back of the eye. So anyways, good imaging here to show that. And I think we've, I think we've highlighted it. And I think you're right from the very beginning. I think Matt said that, probably something should have been done then, because this is what happens now. This patients had significant RNFL loss and had significant visual field loss. But at the time, the patient was seeing well. Patient had good pressure control, was better than before. Chamber was deep. The nerve was great. Visual field was great. So everybody said, listen, let's leave it alone, which I think is understandable. But this is the problem that happens when we leave malignant or leave angle closure alone in that way. I mean, there's no reason why an angle should remain 0 and 1 post-phaco. There should be no reason why something's wrong here. Smell it out and figure out what's going on, whether it's plateau iris, whether it's malignant glaucoma, effusion, whatever it may be. So that's it's a really good lesson here.
Yes.
Okay, Ala, we'll move forward just to keep on time.
Sure. So part of digging deeper into the root of the problem and figuring out what's going on, I actually happened to find a couple of UBMs that were done. Unfortunately, all of them are post-ops. I don't have a pre-op, like pre-phaco. But if you look at the 2017, 2020 at February and even in March, now all of them are showing like contact of the lens from the anterior positioning of the eye wall with the iris. But you can notice that the contour of the iris is even different. You see how it's like in reverse pupillary block or concave position. And here it's more flattened, and here it's kind of more pushed anterior. And I kind of drawn those lines to show that even you could argue that the anterior chamber depth, if you calculate like the distance from the anterior cornea till the anterior eye wall, you could argue that the distance is kind of shorter. And this kind of tells me a story that this is a process that have been building up, and probably we've reached a stage where the anterior positioning was enough to keep the iris opposed against the angle and cause PAS eventually. So in summary, now you have this patient who used to be primary angle closure and now primary angle closure glaucoma in the left eye, uncontrolled pressures on full maximum medications, including acetazolamide, pressures reaching up to 40, 360 degrees of PAS, and with anteriorly positioned eye wall. And we've echoed about the diagnosis. I guess we could do the second poll and see what people would do as the next step.
You know, if we're trying to be clean with our nomenclature, I would change this. This is no longer a primary angle closure disease. This is a new process. It may have been present at initial presentation, but this is malignant glaucoma, which is not the same thing as primary angle closure glaucoma. Certainly those two things can intersect, but what we're seeing now is a different entity than primary angle closure disease.
Yes.
We just started the poll.
Like-
I don't know if you can all see it. Go ahead and vote, and we'll ask the panelists, what will you do here? I think Manju, you're quite right with the nomenclature. I think it's good to be clear about the terminology. Okay, so what are we going to do here, guys? And then George mentioned it too. I mean, the patients we talked about how a unicameral eye, by doing an iridozonular hyalodectomy, vitrectomy, should basically prevent malignant glaucoma, but this patient still had persistent. In fact, probably had it pretty early on. And George, I think you mentioned that can get blocked still, right? You can get fibrin, you can get vitreous that can block that channel. And that can certainly happen when you have a stormy course postoperatively, inflammation, pigment, whatever else that can do that. So, okay, so let's just share the poll results here. And so
I'm surprised actually. So, yeah.
10% still want to do trab though.
Well,
combined trab,
despite all of what we talked about.
I think it's all your Saudi friends.
Yeah, I mean, I think
I've seen more retina people in the group, so I don't think so.
I mean,
Looking for business.
I have filtering surgery on my radar. I would say for sure the patient has advanced disease. We've watched progression. Of course, the scare with doing filtering surgery is that you're gonna go from a subtle malignant glaucoma to a serious one. So if I were to do filtering surgery, which I would be considering, I'd be having a conversation with the patient about a stepwise approach and about their medication tolerance post-operatively. If I were to go the filtering surgery route, it would be a valved tube shunt, so an Ahmed valve in my case.
Yeah, I would just say that I think that, to counteract that argument, though, I think that, to do the procedure, you're probably going to do the vitrectomy, you probably need to do some work on the angle and stuff. And so, there's still a reasonable chance that you can get the angle open, and maybe consider doing it as second step. I totally agree, though, that, I mean, this person is perhaps heading towards something subconj, but I don't know. I've always tried to, I've been amazed at opening the angle up and getting dramatic pressure reductions, even when the disease is pretty severe, and that can be often enough for these patients. So, but no, you're right. I mean, we can't just exclude it, I guess, is the point. I think those people who voted probably would consider doing something else as well with it, like a vitrectomy.
I'd also add that, now she's 3+ years with PAS that were really only gone for a few months. It seems like. So, relying on the trabecular meshwork to be fully functional is maybe gonna lead to disappointment. So I would say at least a Schlemm's canal intervention beyond sneakulolysis would be a good call. But I think Matt's point is a really good one, that you have to the conversation has to at least start to introduce the concept of potentially more outflow surgery.
Yeah. So I'll bring up this paper, which was published back in 2014 by Devish Pharma and the GAS group. And basically it touches on the incidence of malignant glaucoma after cataract surgery. And unlike what most of the people would think, that malignant glaucoma has to show up as a dramatic shallowing of the anterior chamber, it can happen subtly. Now, key things in this paper is that one of the risk factors is of having such cases after cataract surgery is in females. All of the patients actually were female in this paper, with hyperopic refraction, short exit length, and small anterior chamber depth. And this paper kind of also laid out a stepwise approach on how to tackle malignant glaucoma, starting with cycloplasia and aqueous suppressants, followed by IZH or iridozonular hyaloidotomy using a Diag laser, and then going with an anterior chamber reformation with a viscoelastic, meanwhile pushing the IOL, what we call an IOL pushback, so that to push back the lens into an anatomical position in a pseudophakic eye, obviously. And then the last step would be iridozonular hyaloidovitrectomy. This is an interesting picture that they had in the literature. And this is not for our patient, but basically demonstrate how a patient can go from a normal in the bag effective lens position, and week 4, when this patient have developed malignant glaucoma, you can notice that chamber depth might have changed a little bit, but then you have loss of the lens vault, like you have a lot of touch between the IOL and the iris, and this could be a very subtle change that happens. So basically, here's what we've done. We've went for a pars plana vitrectomy, 23 gauge with iridozonular hyaloidal vitrectomy. We've done 360 degrees goniosynecholisis. We've placed eye stents, and we've done scleral windows as well. So I'm gonna optimize the video so that it's a better quality for the audience.
So I'm gonna play the video all, and then we'll just have to wrap it up. So maybe you can play the video and then get right to the result, and then take home messages.
Sure. Yeah. So the video is not working.
It's very stuttery. Is it optimized for you?
Yeah. Yep. I optimized it actually. Oops. Let's try again. Maybe not optimizing it. Let's. Yep. How is it now?
It's still very choppy.
Is it then? Yeah, still choppy.
Ike, what was the rationale for scleral windows here? Or Allah?
Yeah, so basically the main concern was, since this could be a condition where we might have a choroidal expansion or recurrence of the issue. We didn't want like an additional factor of having posterior pushing mechanism. So we've had the scleral windows done so that in case of any effusions that happen later on in the post-op period, then the scleral windows are there prophylactically and would help out with the drainage of the fluids, and especially in a very small eye. I'll be sharing the YouTube link with the audience, obviously for the. Yep, I think it's working well from your end, Ike.
Is it playing smoothly? I just optimized the video here. I don't know if it's helping or not here.
It's a little choppy, but
it's much better. Yep.
And did the examination show a reason for that IZHV from 2016 or 2017 to have failed?
So when I looked at it, it looked patent. There might have been some iris fibers stranding, but overall, when I looked at it, it looked
it wasn't patent. I mean, in the OR, we knew it wasn't patent. So I think that was going on there. Can you see the video okay now, hopefully?
Yeah.
And so it wasn't patent, Ike, because the iris had just closed down, so the iridectomy was too small?
No, the iridectomy, you can actually see the iridectomy up there and you look in the video, but there was a membrane that was present there, which you will see that sometime, right? Just with inflammation and fibrin. So exactly, that's exactly what had happened there.
Okay.
So do you want to talk through the video there?
Sure. So basically, we started off by doing a 360 gonio to examine the angle. We started off by doing goniosynecholisis for the nasal part of the angle, as we're gonna place eye stents. We've decided to place 3 eye stents. So you can see this is one, and I guess we can speed up from this part. Yep.
So I think you made a great point about chronic PAS, and apposition can lead to chronic dysfunction of the TM. I think that's a concern here. So the idea would be to put some stents in to perhaps help to bypass.
Yep. So the next part, we're doing our other 270 degrees of goniosynecholisis. Over here, we're using the DVX mirror, which gives a non-inverted view. Then we've used the pars plana trocar that we've inserted first we've entered the vitreous cavity with a vitrector and went through the original iridectomy, and we've performed IZHV again, and we've expanded the peripheral iridotomy as well. So therefore, performing the IZHV part, we did some limited vitrectomy just to debulk enough vitreous to deepen the anterior chamber. At one stage of the surgery, the chamber have deepened significantly, and obviously, you're seeing Ike over here injecting some viscoelastic while doing the vitrectomy as well. And this is to deepen and maintain a deep chamber. So after the chamber had been formed, this is when we've decided to do the scleral windows. So we've opened up in the infranasal quadrant parotomy. We're doing a partial lamellar scleral flap, triangular form, and we've cut it apart. You can use a Kelly punch instead. And we just sutured the conch. We don't suture the flap again. We just keep it open. And I guess this concludes the procedure. Yeah, I guess we can move to the slides.
Okay, I'll back to you, buddy.
Sure. So we're wrapping up right now.
So yeah, Manjul, I mean, you know, the scleral window was kind of we've had situations where we've had persistent effusions after these surgeries, and I think I've seen enough of these that I kind of feel it's worthwhile to do this when you have a picture like this that is, you know, complicated. I think the other thing is on the UBM, there's a question about whether there might have been an effusion there. We didn't have a B scan to show you there, but there was some suggestion that there might have been something there too. I mean, and then there was also the debate about whether the IZHV was open or not, right? Whether it was patent. Sometimes you can't tell very well when you look at clinically, although in the OR you could tell when the cutter went through, basically there was some resistance there. Yeah. It was not going through there until you cut it. And so I think all those things that preoperatively kind of made you think about it. And so the morbidity of doing a cut down, I mean, I guess we do enough of them that it felt comfortable to do it. But whether you had to do it or not, it's a question, I guess, to debate. But I think I've just seen, you know, too many uncertainties early on and then after as well.
Sure.
Yeah, and I guess for people who are wondering about the rationale for gonius suniculitis, I know there's a lot of conceptions and ideas about doing gonius suniculitis, especially with phaco. This is a very excellent editorial made by Ike and George there, which reviewed over 17 literature articles about gonius suniculitis randomized trials. And basically they've looked all over it, and the recommendation actually is in favor of doing gonius suniculitis. And I guess because we're running out of time, so I would just advise everyone to look into it. Maybe I could summarize it at the end of our talk. I would like to tell them that when we saw the patient lately, unfortunately it was during COVID, so we're kind of limited on what tests we can do. So we couldn't like repeat a UBM or refraction. But I could tell you that the angles were like deeply open. Like since day one, she was like 7 or 8 central corneal thickness deep. Angles are open now to grade 4, which wasn't even achievable from the first surgery. And last time I saw the patient, the vision have improved to 20/40, and the pressure was 16. Still on 3 medications, but what we're doing right now is like weaning her very slow so that we don't want any surprises to happen during COVID. But the plan is to wean her off everything. And as Ike said, that at a certain stage, we might be thinking of subconjunctival route. So the take-home point that I wanted to bring into this case, that to always have a very close eye and watch for cases with abnormal ocular proportions. I gave one example as relative anterior microphthalmos. This might have not been exactly the case. But then whenever you have doubts about the chamber anterior segment measurements, then you have to expect some certainty of intraoperative and postoperative complications to happen compared to a normal eye. So proper identification, modification of your IOL power selection, and some measures taken during surgery to maintain the chamber depth are crucial. Always consider iridozonular hyaloidovitrectomy in small eyes to prevent or reduce the incidence of postoperative malignant glaucoma. And always remember that malignant glaucoma can happen postoperatively in subtle clinical findings. It doesn't have to be necessarily in a dramatic way. This is something to have a high index of suspicion for.
And I would say goniosynechrolysis could actually be a good option to do in glaucoma cases. This is a perfect example where not to rush for a glaucoma procedure, go for a trab or a tube, and then you end up with worsening of the malignant process over here. And I would say always address the IOP raising mechanism. Ike always tells us as fellows that synechia is not a diagnosis, it's more of a manifestation of something. So we always have to dig deeper and find a cause for that. So the reason why I was digging deeper is that I was intrigued why this 360 PAS process have happened. Otherwise, if I would have dealt with it as a diagnosis, then I would have ruled the patient to be combined mechanism, which is not. And I guess that's it. Thank you so much.
Okay, thanks, Ala. I think we just have a couple of minutes. I wonder if anybody else wants to add any comments. I hopefully a lot of lessons for everybody watching. I think it's a really instructive case thinking about angle closure and mechanisms and anatomy and the manifestations of what we see with those processes. I'll hand it over to George or Manjul. Matt, maybe George first. Any last closing thoughts?
Yeah, so
Speechless.
I think George is frozen. You're frozen now. Maybe I'll go to you, Manjul.
This was a tough case. A lot of things to manage, including patient expectation. They probably have a certain expectation of having this fixed years ago, especially since the right eye went so well. Again, I think, as Matt said, we have to set this patient up for the possibility that his or her outflow function doesn't improve depending on what their medication tolerability is. One thing to be mindful of is, we haven't done a complete vitrectomy. Obviously, it's still an anterior vitrectomy. So the decision of what kind of filtering procedure, subconjunctival procedure, if indicated, should bear in mind the fact that there is, I believe, a superior iridectomy that goes all the way into the vitreous space. So you want to make sure that you don't do a trab right there. You could pull vitreous, you could, have a pressure gradient that brings vitreous forward. You don't want to necessarily put your tube ending right at that iridectomy either. So plan your next surgical approach appropriately.
Thanks, Manjul. Matt?
Yeah, I think a very tough case, and I hope this patient does well. I'll be interested to see, because I think it'll give me renewed confidence to stick with the conservative. I think my other concern when I was seeing that cut down is I'm worried, because I'm in my head, I'm thinking this patient's going to get subcon surgery, that I want to preserve the real estate. Another consideration, I have had some patients who've actually had a vitrectomy and still had malignant glaucoma. So if you are going to do filtering surgery in patients that have vitrectomy, I do think a pars plana tube in these patients is an option. So this particular patient, I don't think it is a very good option right now. You do have to be careful when you put the pars plana to make sure that even when you're going in, that you don't get a little plug of vitreous going with. And it's hard to visualize these. They're hard to YAG. So there are some considerations, but it sure would be nice to not have a filtering surgery in the front of the eye, which again is the whole reason that you guys did this approach. Because for those of us who've dealt with a flat chamber with malignant glaucoma, it is very, very difficult to manage. With that said, an Ahmed valve with viscoelastic, you could potentially tie off the Ahmed valve at the beginning. There are some measures to take, but I've tried taking those measures and still ended up with a flat chamber in the early post-operative period. So great case, Ala.
George, there's been a question about how do you do an IZHV. Do you want to briefly just mention how you do it, although it was in the video a bit, but anterior, posterior, and what do you do?
Yeah, so there's the anterior posterior approach. From anterior approach, which is the one I'm most accustomed to, is going through your main incision. You have to put enough viscoelastic that you dilate the area where you're going to place your vitrectomy probe. You create a large enough iridectomy. There's a couple of modes. It depends on what machine you're using, but some machines can get an iridectomy mode where you're just getting one cut rate at a time and with high vacuum and just creating a nice enough, big enough opening. And then basically you're diving down into the vitreous cavity with the port facing down towards the nerve, and kind of going along the sclera, not pointing too down, but just along the scleral wall. So if you're going in that iridectomy site, you're going through and towards the scleral wall and cutting throughout, using your vitrector, cutting throughout and creating that unicameral line. Honestly, the second you get that cut of vitreous, you typically get an increase of your anterior chamber depth. And I just want to point out that for this case specifically, you know, if there was inflammation and it caused this membrane, going hard on your steroids early on, and I think I noticed you guys injecting some dexamethasone or some sort of steroid at the end of the case. It's really key to avoid this happening again. So going hard on the steroids, even injecting subconj at the end of the case, is something that you really have to consider.
Fantastic, everybody. Well, listen, it's been great. Sorry for the interruption. Thank you, those of you who came back to see us still. And Olive, thanks for presenting. Really interesting case. Michael had a great presentation earlier as well on cataract and glaucoma. A lot of interesting pros from that as well. So I do want to thank, of course, our panelists. Thank you, Manjul, for being here from Michigan. It's like you haven't even left. Matt, of course, down the road. Thanks so much, Matt, for always your great comments and thoughts, and of course, George as well. It's like we brought the band back together here almost. So good to see everybody here. And thank you all for tuning in here as well as always. Thanks for your comments on the chat group as well. We tried to answer some of them, and we'll hopefully have more things to discuss in the future. Our next rounds is going to be on Saturday, as we said, Saturday afternoon, the surgical feud, a theme off the family feud. We got about 20 international surgeons who will be debating on various scenarios and different videos and what to do next, and pit people against each other. They won't know what they're arguing or what they're debating or what side they're taking even, but they will be debating against each other. So that should be fun. And then, of course, everybody is getting back to work. So we're just deciding about the best place to do rounds, whether it's best to do them in the evening or on other times. So we'll be sending out maybe some surveys to you all to see what works out. But either way, it's good to see everybody. A lot of rounds are out there, and we'll see what one of the others. I still have too many rounds on my calendar I have to get to, and I'm sure many of you as well. So anyways, take care, keep well, be safe, and keep on learning. Learning doesn't stop, and we look forward to getting back to take care of our patients, as many of us are now already. So thank you very much. Bye-bye.
See you. Bye.
Thanks all.